So we have put the patient on ventilator. That means now we can provide ultra low lung protective ventilation. So we have to give the patient a tidal volume of 3 to 6 ml per kg body weight. The lower the better. Second, we have to target a P flat of less than 25. Third, we have to use a PEEP. The exact value is unknown, but we have to use a moderate PEEP around, let's say, 8 to 10 centimeter of water. We have to have a modest oxygenation goal or SpO2 goal, SpO2 target 88 to 92%. Number 5, modest CO2 removal goal. So you can tolerate a little bit of acidosis. For example, around 7.25 to 7.35. Right. So these are the settings that you have to put in our patient who is put on ECMO initially. Why you are doing this? So this is doing two things. Number one, it is giving the lung time to recover. At the same time, it is decreasing villi, which is barotrauma, because you are avoiding a high area pressure, decreasing volute trauma, because we are able to give a very low tidal volume to our patient. Atelectrauma, because you are using a PEEP, so it will prevent atelectrauma. Because you are using a modest oxygen goal, this will prevent ventilator-induced oxygen toxicity. Because we are targeting a P flat of less than 25, it can also decrease the driving pressure, and that will improve the mortality rate. So we are able to achieve these two things. Now, when to consider weaning? So there will be a situation when the lung will start improving. What do you mean by that? That means on similar ventilator settings, lung mechanic improves. So we have put the patient on ventilator with the setting, and the next day you come and you see, what do you see? If the patient is on VCV and you see the P flat is actually decreasing on same ventilator setting, that means the lungs compliance is actually improving. And if the patient is on PCV, we have put on pressure control ventilation and you see the tidal volume is increasing on same pressure control. That also means the lungs compliance also increasing. And thirdly, the ABG is better, is actually improving. There is no oxygenation problem, there is no ventilation problem, or they're actually better than before. So these are the things that you have to assess in your patient on daily basis to consider weaning from ECMO. And how it exactly done? So in the beginning, this is the ECMO, this is the ventilator. So in the beginning, ECMO support is maximum and ventilator support is minimum. Right. As the native lung it starts improving. And here what you can do is you can come down on ECMO. How? By decreasing the sweep gas flow, but keeping ECMO blood flow and anticoagulation intact. And at the same time, you can increase the ventilator support. So when the native lung improved significantly, that is your clinical decision. Every day you're seeing the patient, the compliance has improved significantly. It is at that time what you can do is you can even decrease the sweep gas to 0. No sweep gas flow, right? It can be for few hours or overnight. If oxygenation is okay, you can decrease the ECMO blood flow, even decrease ECMO blood to around 2 liters per minute. because now lung is overtaken. So you have to increase the blood flowing through the lungs. So decrease the ECMO blood flow to 2 liters per minute. And in the ventilator part, now we can sustain a lung protective ventilation without causing any injury to the lung. At the same time, we can maintain homeostasis using lung protective ventilation. That means by using tidal volume less than 6 ml per kg of idle body weight, by using a PEEP of less than 12, FiO2 of less than 0.6, we can have a P plat of less than equal to 25, and we can have an AVG which is sustainable with life in this ventilator setting. If patient passes this test, tolerate sweep gas flow 0 with minimal of ECMO blood flow, and a lung protective ventilation enough to keep a P plat of less than 25 and an AVG that can sustain life. That means there is no problem in the oxygenation, there is no problem in the ventilation. If this happens, decannulation can be tried. So this is how you plan to win from ECMO. Usually, in most of the cases, it takes around 8 to 10 days of ECMO, and it is at that time we can start winning or consider winning. If patient improves before also, we can do that. But on an average, majority of cases, it takes around 8 to 10 days of ECMO for the lung to recover, right? But in the first 12 to 24 hours, try to get rid of neuromuscular blocker or pulmonary vasodilator if you're using. You must be able to stop it by 12 to 24 hours of starting ECMO. If you want to do a tracheostomy in your patient, do it while on ECMO. This will prevent sedative use after decannulation, and it can mobilize the patient. We can mobilize the patient fairly quickly, right? So this is how we set the ventilator in our ECMO patient in the beginning, how it benefit our patient, when to consider winning, and how to win. We have discussed today, right? So in the next class, we'll discuss about the troubleshootings. Thank you very much.